अस्सलाम वालेकुम। कैसे हैं आप? उम्मीद है ठीक होंगे। आई एम डॉक्टर मोहम्मद अली रबानी, असिस्टेंट प्रोफेसर एनाटमी, here to bug you again for the next lecture in the series of head and neck. So today we are going to discuss neck. We are going to start neck, and inshallah we will continue this topic for a period of 3 days. What my plan is for the next 3 days. For today, inshallah, we will discuss the osteology that includes the cervical vertebra. Apart from cervical vertebra, I will discuss the two bones that were left in the previous lectures, that is the mandible and hyoid bone. Inshallah, all these bones which are related to the muscle attachments in the neck will be covered here. Then we will have a brief account of the skin, any features that are visible on the surface, and subcutaneous tissue and basic structures, the lymphatics and cutaneous nerves that are present on that surface. Our other focus will be the muscles, the suprahyoid muscles, the infrahyoid muscles, the prevertebral muscles. So my basic focus, my target is to get the basic skeleton of the neck. If you get the understanding of the skeleton of the neck, that includes mandible at the upper end and the vertebra at back and one hanging bone here, the hyoid bone, and the muscles that are surrounding them. If you get the structure, the idea of this, then we will be able to put the structures between them. In the subsequent two lectures, we will discuss the arteries, veins, nerves that are passing between them, the viscera that are covered and present there. So that will be our next topics, inshallah. So let's start with osteology. The first topic, mandible. Let me shift to the 3D model, and let me give me a little overview, then we will shift to the 3D models, and then we will review on this particular slide. Mandible, the jaw, this bone, the largest, strongest bone of the face. It consists of basically two parts and angle between them. This vertical part, the standing part, the one you feel here, this is the ramus. This horizontally lying part, this particular part is called body, and where they two meet, this point is called angle. After this, we will see the features that can be seen on the external aspect, the features that can be seen on the internal aspect, and along the margins. Let's move to the 3D model. Okay, then. Here is the skeleton of the head and neck. Let's isolate the mandible. We have selected the mandible, and let's remove all the other bones. So you are left with this mandible neat and clean. Mandible consists of two parts basically. This vertical part, this is called ramus. This horizontal part, the body, and the between them, here is the angle. Very simply, let me get my tools ready. Okay then. So ramus, body, and angle between them. So let's see the features. Let's move on to the ramus. In the ramus, there is the two processes on the top. There is the process here. This is called coronoid process. This is called condylar process. And in between them, this fossa, this is called mandibular notch. This notch is mandibular notch. This is called coronoid, and this is called condyloid. This is also called the head of the mandible also. And if you consider this the head, obviously the constricted part below it, this would be the neck of the mandible. Okay, this is the head and neck of the mandible. Let's look at the other features. If we see the other features, the external, it is roughly smooth. Here, this part near the angle, this part is rough. This part gets the attachments of the masseter muscle. I'm not talking about the attachments in the detail here. If you just place your finger here and clench your teeth, you can feel the muscle here, the masseter that help in chewing. It is attached here that gives the grooved area here. And then there is an interesting thing that is seen right here. This is the oblique line. This particular line is the oblique line. It is basically the continuation of the anterior border of the ramus. If you see from the front, the mandible, do you remember the origin of the mandible? The origin, you can mention in the comments. The origin of the mandible, what is the origin of the mandible? I'm leaving for you. Okay, the mandible was developed from the two sides and it met in the midline. So here, this point where the 2 points met in the midline, this is called symphysis. This is called symphysis menti. Mentis, mandible ki symphysis mandible. And if you follow them down, there is this triangular raised portion. This is known as mental protuberance. The mental protuberance is more visible if you see from side to side. Here, this triangular process, this area, this is mandible prominence. And the upper margin of the mandible, it gives rise to the teeth. These are the alveolar arch. And you may be able to appreciate a little just below each of the teeth, there are fossa. You may see grooved areas just below the teeth. So these areas are incisive fossae. So this one, these are the incisive fossa. It, there are grooves just below the teeth, just as they were present in the maxilla. And then there is this opening. This is present in the mandible. This is called mental foramen. This is called mental foramen. And mental foramen, it from it, the arteries and veins and nerves of the same name exit to the surface. Mental foramen. Okay. So these are the external features. I hope I have covered all of these. Coronoid process, condyloid process, neck, mandibular notch, ramus, angle, rough area, oblique line, mental protuberance, alveolar arch, incisive fossa, mental symphysis menti, and mental protuberance. Let's look on the interior aspect. So, from the inner aspect, what can we see? Let me show you this particular thing right here. Just in behind the symphysis menti on the posterior aspect, there are raised tubercles. Usually, it is as a rough area. Otherwise, to be more specific, it's pair of raised areas, though two superior, two inferior. These are known as um, genial tubercles. These are known as genial tubercles. Mandibular mental tubercle name is also used for them. So these are genial tubercles. You will read the names of the muscles starting with the name genio, genioglossus, geniohyoid from this. Then there is this very interesting thing that is seen here. There is an opening right here. You can see this opening. This opening, I have to come here to show you the opening because this opening, it is protected by this bony projection. Let's talk about this bony projection first. This bony projection, this is called lingula. Lingula means tongue. It's tongue-like projection, lingula. And if you see from the lingula, if you see it is covering this foramen, this particular foramen, this is present in the ramus of the mandible. This is called mandibular foramen. It is present in the mandible. It is called mandibular foramen. Okay. And just beneath the mandibular foramen, you will be able to see this groove. This is called, you will have to remember the name, mylohyoid. You will today in the today's lecture, inshallah, you will read about the muscle, mylohyoid muscle. So this is the groove for the nerve that goes and supply the mylohyoid muscle, that is known as mylohyoid groove. Okay, and by the name of this muscle, there is another line that is visible here. It is not very much prominent in this particular section, but you can identify the line that is present here, this line. This is called, with the same muscle name, this is called mylohyoid line. So this actually gives rise to this muscle. Very important for telling you this line is that because the area on the top of this line, this area, it is making the floor. On the top of it there is tongue, so this area is below the tongue. Actually mylohyoid muscle, it's making the floor of the mouth, it is making floor of the mouth. Or so the this part, this fossa is above the floor of the mouth, this fossa is below the floor of the mouth. This is above the floor, below the tongue, so it is below the tongue. This is called sublingual, and it is roughly, mandible is just a little outwards. It is present a fossa below that. This is called submandibular. So these are the structures that are present for the that are present in the mandible. Okay, so I think we have covered most, if not all of them. Let's see if there is any more. So let's move back to the presentation. Okay, let's move back to the presentation. Let uh, get a checklist if you have read or seen all of them. It is the largest and the strongest bone. It has ramus, body and angle, ramus, body and angle. External surfaces, you will be able to see symphysis menti, mental protuberance, mental foramen, oblique line, and incisive fossae. Singular will be fossa, multiple will be fossae, AE. If we see on the internal aspect, I'm moving from this picture to this picture, you will be able to see this line. There is an MCQ that mylohyoid line starts below the last molar tooth. It starts below the third molar tooth, so I have put it separately. It divides the interior surface into the sublingual fossa above and submandibular fossa below. In the midline, in the interior aspect, there are pair of two tubercles that are genial tubercles or mental tubercles, and mental spines or genial tubercles. And here is another fossa that I did not discuss there. If we follow the inferior margin here, just near the midline, this is the digastric fossa. This gives rise to attachment to the digastric muscle. So it is a little flattened as compared to the rest of the sharp border. So then in the ramus, on the upper aspect, we saw the coronoid process, condylar process, mandibular notch, neck of the mandibular, two fossa we left. There is a fossa just in front of the head, in front of the neck of the mandible, that is called pterygoid fovea, pterygoid fossa, and there is a fossa just in front of the ramus or behind the wisdom tooth or third molar. This is called retromolar fossa. These are two fossae. And one last thing that we did not discuss was the mandibular canal. So mandibular canal is basically the canal that is connecting which two structures? That is connecting the this mandibular foramen to the mental foramen outside. Mandibular foramen to the mental foramen outside. So if we look from inside, it would be something on this line. It would be something like, it will go like this. If we look from outside, it would be something like this. So this is the mandibular canal, and actually this canal does not stop at the mandible. It continues all the way below the teeth. So this canal is a very important that you must remember, because this canal, this canal, it runs and it carries all the structures that are necessary to supply the lower teeth, the mandibular arch. So it contains the inferior alveolar nerve and the artery and veins that is supplying and draining the lower teeth respectively. And a part of this nerve, a branch of this nerve gets out from this mental foramen to supply the area of the cheek. So this is about the mandible. Let me get to the point zero and we will move to the next set of bones. So this is the mandible. This is we talked about. Let's move on. Next bone is the hyoid bone. It's a very tricky bone in the sense that it's very interesting in the particular sense that this is, I think, the only bone in the body that is independent of rest of the skeleton. It is not connected to the any part of the skeleton, axial or appendicular, with the body. Let me show you where does it lie. So if we look at the bone here, you can see it is floating, almost floating. It is only connected by muscles and ligaments that are not shown here. This is the hyoid bone. This is the hyoid bone. The hyoid bone, it is originated from the partially second and partially third pharyngeal arch. So the basic take home message, the bare minimum you should know about the hyoid bone is that it the name of the three parts. Let me move to the presentation. The bare minimum is to know the three parts. This is the body. The projections, smaller one that are on the top, that are the lesser cornu, and the projections that are going backwards and sideways, that are bigger one, that is the greater cornu. For most of the practical purposes, knowing the names of the three parts gets you by. However, we are the students of anatomy and we are the teachers of anatomy, so we won't uh, let you go by such easily. So it has body. Body has a little convex anterior surface and a little concave posterior surface. Anterior surface is facing like this, anterior and superiorly. Let me show you right here. This is the anterior surface. Okay, this is the anterior surface, and the anterior surface, the thing that is to be remembered here, so it has two surfaces. The anterior surface here is the posterior surface, and there are of course two borders, the upper and lower one, and there is this in the midline. This ridge in the midline, it is called the median ridge. Simple. The body has convex anterior surface divided by median ridge, posterior surface, that is red, and median ridge. Another thing about remembering for the exam point of view, that these two parts, the body and the horn, they are joined with in early age, या कहना चाहिए before middle age. There is a fibrous joint here. They are not as a single bone. That is a joint, fibrous joint between these two. But with time, as the age progresses, they fuse with one another and they become a one bone. So we talked about the location, the origin of the hyoid bone. Let's move on to the cervical vertebra. Give me a second. Okay then, cervical vertebra. These are the parts, these are the seven vertebra C1 to C7, they are labeled, that makes the skeleton of the neck. These are 7-1, C1 to C7. You can just uh, remember them by this name. Otherwise, you can give you must know their alternate names. There is Atlas, Axis, then C1, 2, 3, 4, 5, C3, 4, 5, 6, and C7 is also known as Vertebra Prominens. Let's remove them. So this is the vertebra. You see the atlas, the axis, and the other vertebra. I want to bring your focus to the curvature. The cervical vertebra, it's curving forwards. It is convex in the front aspect, concave on the back aspect, and uh, so this is it. So let me get out the other things. Okay, so this is cervical vertebra. Let us focus on one typical cervical vertebra. Then we will take it from here and we will discuss what we can in the presentations also. Let's look at the bone. How does it look? What are its parts? What are their features? Okay, this is the cervical vertebra. I'm looking at from the front. If we look at from the above, we may be able to see like this. So this is the anterior aspect. Here there is a body. Let us look at the parts first. Here is the body. This is the body, and this is a very complex as compared to the thoracic vertebra that you have must have read by now, and the lumbar vertebra. This whole thing is the transverse process. This little thing between, first let me tell you the lamina. This is this part from here to here. This is the spinous process. Okay, from here to here. This is the lamina, what we are left with, and between them, from here to here, this is the pedicle. So these are the parts of vertebra. Cervical vertebra I'm talking about right now, but they go for all of the others. So there is a body, there is a transverse process, a very little pedicle. It is thick and short, moving backwards. There is a lamina, and there is a spinous process. We will go to the features of them one by one. Let's start with the body. Let's start with the body. If you look at the body, it is smaller as compared to the vertebral canal. Vertebral canal is the largest here because as you move down the spinal cord must be largest, must be thickest in the neck region, because as you move down, the motor nerves will exit, the nerves will keep on exiting, and the spinal cord thickness will go on decreasing as you go, and it will end at the coccygeal segments at L1. So first thing about the vertebral body is it is smaller as compared to the this canal. It is smaller than this canal. This diameter is higher as compared to this diameter. So transverse diameter is more than the um, anteroposterior diameter. Let's see the convexities and concavities. Let me draw a line on the, okay, let me get the bone straight a little. Okay, let me draw a line, and you will be able to appreciate the curvatures. Let's draw a line here. Okay, I think I'm not allowed to draw the line on the object. Okay, leave it. We will do it without the pen. If we look here, the transversely it is concave. The lateral edges are raised. The center point is dipped. So it is concave when we're looking at the anterior surface. And when we look at the other surface, it is roughly convex to um, beveled. Beveled surface is like the knife. Whenever the word beveled is used, it means that it is like something like this, like the edges of the knife are beveled. So this is called bevel. So this is the beveled surfaces are present. So it is beveled anteriorly and posteriorly. Let's look at the inferior surface. Let's look at the inferior surface. The vertebra will have to fit into their counterpart below, so it will have the opposite. So it is from side to side. It was it is side to side. It is concave. From here, it will be convex from side to side. It is a little difficult to appreciate here because the convexity from front to back it is very prominent. From front to back, it is concave. From front to back, it is concave, but from side to side, it is convex. The convexity, I'm not very able to show you the convexity right here, but you can take my word for it. So this is the body. We'll talk about the relative size as compared to the vertebral canal, the curvatures on the top surface and the inferior surface. If you look at the anterior surface, it's mostly flat, but it's a little concave in the front direction. And another features that is interesting on the back aspect, these are the small openings. These are the openings that helps in the drainage of the veins, that drainage of the blood from the body of the vertebra. So those veins are known as basivertebral veins. The veins, ये opening किसके लिए? This opening is for basivertebral. This opening is for the basivertebral veins. So this is all about the body. Let's move to the pedicle. What is the when we're talking about the pedicle, we say what is its direction, where it is attached. So it is going purely backwards, as opposed to the thoracic and lumbar region. They may be going outwards or inwards, so it is only going backwards, so it's a backward direction. If we look at the sides where it is attached on the body, so let's look at the side. Yes, here it is attached roughly to the middle of the body, or sometimes to the upper part of the body. So it leaves the body with the two notches. The part that is superior to the pedicle, let me get it here. This is called superior notch. This lower one is called inferior vertebral notch. And between the two consecutive vertebral notches, when the next vertebra will be attached here, it will give like rise to intervertebral foramen. I will go to the intervertebral foramen by the end of discussing the typical cervical vertebra with you. Let's look at the um, transverse process. The transverse process, it's a little complex. Here is compared, it is a little complex as compared to those of the thoracic and lumbar vertebra. It has three parts: this anterior, this posterior, and the one joining them. So this is called posterior. Simple, remember the relation. Posterior component, posterior root is also used for it. This this part is called posterior tubercle. This is the anterior root, and you may have guessed it by now. This raised portion, is the tubercle, and there is middle one. In the middle, what is it? In the middle that is joining the two, that is called intertubercular lamina. or costotransverse. The word we use for this is, because it is between the two tubercles, so it is called intertubercular or costotransverse. Let me get you why you called it costotransverse. And then we are left with this opening. This is the opening in the transverse process. So this opening is called the foramen of the transverse process, or a fancy word will be foramen transversarium. So this is foramen transversarium. This is the part that is making the transverse process. Let me tell you what is the reason behind the embryologically. The original transverse process is called the transverse process. The transverse, I think there was a better word for it. I don't have in mind right now. If you remember, please mention in the chat. There was the transverse component, the original, and transverse element, and then there is the costal element. In the thoracic region of the skeleton, it is very clear. The transverse region, the transverse component makes the transverse process, and the cost transverse element makes the transverse process, and the costal element makes the costal part, that is the ribs. It's very simple in the 12 thoracic vertebra. But in the rest of the parts, in the cervical parts, in the lumbar parts, in the sacral parts, there is no ribs. But embryologically, the costal element was there. So where does it go? It merges back with the transverse element and becomes part of it. So I will be limit myself to the cervical vertebra here. So this part, the anterior root, the anterior tubercle, and the costotransverse, this is from the costal element. This was from the embryological costal element. And this posterior part leading to the posterior tubercle, this is from transverse element. That is why you get the name costotransverse lamina. Yeah, costotransverse ridge or anything costotransverse, that is costotransverse bar. So this is about the transverse process. Let's move on. Give me a second. Let me um, drink a little water here. Okay then. So we did the transverse process. That was the most difficult one. The rest is the smooth sailing from here. Let's remove everything. Let's scan in the position right now. So we did the transverse process. Let's look at the other structures. Okay. I usually get in trouble in using this. Okay. Now let's look at the lamina and the transverse process first. This is the lamina. What is the direction of the lamina? The direction is very simply backwards and medially. This is the backward component, this is the medial component, so it is between them, backwards and medially. Let's look at the side. Is there any slope or not? There is almost no slope. It is almost horizontally, so we will only say backwards and medially, unlike the thoracic region where we say backward, medial, and downwards. So this is it. The upper part is roughly, let's see, what does the, let me get this straight. How does the upper part is thicker as compared to the lower part? That's it. They meet in the midline and they form the they meet in the midline and they form the joint to form the spinous process. The spinous process in the cervical vertebra, it's very interesting in the way that it is the only spinous process which is broken into two parts. It is bifid. It is bifid. It is bifid. That is the thing you have to remember. And let's look at the side. Is there any slope or not? Okay, let's look at the side. Okay, it gets irritating sometimes. Uh, yes, it's almost, there is a little but almost no slope. In the anatomical position, there is almost no slope. There is almost horizontal. A little downward slope, but the focus is on the little part. So this is it. Then last thing to see is the articular processes. You can see the articular this projection. These are the articular processes. The one going under the top, this is superior articular process. That is the inferior articular process. They will have facets. Differentiate between the articular process and the facet. The whole projection of the bone is the articular process, and the cartilage where they actually form the joint is the facet. The on the superior one, the facet will on the back. The inferior one, the facet will on the front. Let's look at it. The superior articular process, it's both of them are projecting up from the junction of the pedicle and lamina. From the superior articular facet, it is directing backwards and upwards. You can see it is mostly directed backwards and upwards. It does not have a medial or lateral component, as you know from the thoracic and thoracic and lumbar regions. Then there is inferior articular facet. It is moving mostly downwards and forwards. There is a little lateral component to the inferior one and a little medial component to the superior one, but it is negligible. Their major direction is forward and downwards for the inferior and backwards and upward for the superior one. Most are almost so this is the typical cervical vertebra. So let me get back. Okay, so let me get back to the presentation. Let's quickly revise what we have done till now. We talked about the kidney shape, more transverse and anteroposterior diameter is smaller than the vertebral foramen, concavity in the transverse axis in the superior surface, convexity in the transverse in the inferior surface, concavity in the convexity or beveled surface on the anteroposterior in the superior, concavity in the anteroposterior in the inferior surface. These convexities and concavities are little more better seen here. The convexities and concavities I'm focusing so much on, it's this because this raised portion, the concavity is the upper surface, this raised portion of the body is called uncinate process. This makes a joint with the body. So this is an additional joint that is present between the two bodies of the vertebra. The uncinate process with the medial aspect of the lower half of the body. So this is uncovertebral joint, and neurocentral joint is also known as this. This is present between this raised lateral margin of the upper surface of one vertebra and the convex lower part of the lateral surface of the vertebra above. So this is about uncus, posterolateral lip, concavities and all that. Pedicle mostly below uncus hai, and it is moving backwards. Here you can see it is intervertebral foramen. Intervertebral foramen, it will have one pedicle of the vertebra above it, pedicle below it. Behind it there will be zygapophyseal joint. Zygapophyseal joint is the joint that is present between inferior articular process and superior articular process, and in front of it there is uncovertebral joint, neurocentral joint, and intervertebral joint. So these are the boundaries of the intervertebral groove, and from sulcus and from it the nerves will exit. The transverse process, we talked about the foramen transversarium. It is present in all the seven processes. We talked about the posterior bar, posterior tubercle, anterior bar, and costotransverse bar and intertubercular lamina. The thing I did not discuss was this. The anterior tubercle is the largest for the sixth cervical vertebra, C6 vertebra, that is known as chest neck tubercle या carotid tubercle. We talked about the lamina moving in backward in midline direction, vertebral foramen large, triangular, larger than the thoracic and lumbar, larger than the body, We talked about the articular process in their directions. We talked about the spinous process. Okay, let's move on to the atypical vertebra. So the typical one, they consisted of typical one that we just discussed. They consist of C3, C4, C5, and C6. These are the typical ones. So we are left with C1 and C2 and C7. So let's see what is special about them. So एटलस एटलस एक रोमन मिथोलॉजी के अंदर हुआ है जिसने जमीन को उठाया हुआ है वो आई थिंक टाइटन्स वी टॉक अबाउट देम एज टाइटन्स दो इसी ने एटलस ने आपका पूरा सर उठाया हुआ है लाइक दिस सो दिस इज द नेम behind for that. So let's see the atlas here. So this is our skeleton. Let's look at the atlas. So this is this one that is giving support to the occiput, that is giving support to the base of the skull. So this is atlas. You will see it has a very peculiar shape. What differences can you find? It does not have a body. It does not have a body. That's a very big thing. It does not have a body and it does not have a big spinous process. So what does it have? So this part, if you look at it here, this part, these are divided into two arches. There is anterior arch and there is posterior arch. So this is the anterior arch. This is the posterior arch. You can extrapolate all the information from this picture. These are the two arches, and on the midline there is this tubercle. There is posterior tubercle and there is anterior tubercle. Simple. The rest of the part, that is called the lateral mass. That is the lateral mass. And here is the transverse process. So these are the parts. So we just talked about the arches. There is the anterior arch with anterior tubercle, posterior arch with posterior tubercle. Let's talk about the transverse process. It will have the same anterior and posterior bars, but there is only one tubercle. That is basically the posterior tubercle that is surviving here. Foramen transversarum is on the same point, and that's it. And the articular surfaces, there are two articular surfaces, one on the top aspect of the, let me remove the pen, one on the top aspect of the lateral mass and one on the bottom aspect of the lateral mass. So these, the top aspect, this is helping in making the joint with the occipital bone, occipital condyle, that is making the atlanto-occipital joint. As you can see from here, this is kidney shaped, and if we look from the side, if we look like this, it is concave, it is having a dip. If you look on the inferior aspect, you will be able to see the, this is the inferior atlantoaxial joint. It will be made here. It is usually circular and it is roughly flat as compared to the atlanto-occipital joint. Which movements are possible between the two? The flexion movements are done on the top joint, atlanto-occipital joint, and is mostly anteroposterior flexion. And this joint, it helps in the rotation. So when we rotate your head, your atlas moves along with the rest of it. And we did most of the things. We're just left with one thing, that is the articular process. Here you can see this is the articular process. We'll just look at the dens in the next atlas axis slide. So this is the articular process where the dens, the prominence of the second artery vertebra, that makes a joint here. And that leaves us with one last thing. There is a medial prominence in the lateral mass. This, the medial aspect of the lateral mass, there is a prominence. This prominence gives rise to the attachment of the transverse ligament, this ligament. So Here the transverse ligament is attached, and in front of this the dense bone comes, and it helps to place dense in its position and support and stop its uh, sliding front or back of it. And this is the ligament, that's the point that may break during the hanging fracture, and the dens goes back into the spinal cord as the last act of life. So that's about it. You can take a screenshot for the revision. Otherwise, we talked about the wider cervical vertebra. I did not use that word. It does not have the body centrum. There is anterior arch, there is anterior tubercle, there is posterior arch, there is posterior tubercle. On the I did not mention that on the post top of that there is a flattening of the posterior arch. Actually, the vertebral artery, as it was moving over the posterior arch into the vertebral canal to go into the foramen magnum, so it was passing right here. So there is a groove for the vertebral arch. There is a lateral mass on the superior aspect. There is facet. In the inferior aspect there is facet. The upper facet is concave, kidney shape, making atlanto-occipital joint. The inferior facet is relatively flat and round to oval in shape, and it is making atlanto-axial joint. Then there is a transverse process with the both anterior posterior bars. There is no coastal transverse, and there is only one tubercle that is the representative of the posterior tubercle. So here is the axis, almost same as the typical joint, but the thing that is different here is this portion, that is the raised dens. And let's see in the 3D model how we can look at it. Okay, let us get to the point 0. Okay. Okay. Okay, let's select these two bones. That is the atlas, that is the axis. Let us select these and remove the others, and you can see their relation here. You just saw the atlas and the axis. It will have this. You can see the body, the dent. This is the dens that is running between the two. It is embryologically, actually, it's embryologically speaking, the body of the C1 that did not fuse with the C1 but fused with the body of the axis below, and it gives the axis on which the atlas rotates. So let's look at it. It has the dens, it is the raised portion, it has the articular facet that will make a joint with the anterior arch of the atlas above. Okay, and here is the then another articular process on the posterior aspect. It is joining, basically it is joining the transverse ligament that holds them together. It is making a joint with that. Both of these are synovial joint, and it stays here, and the atlas moves on the top of it as a pivot joint. Then there is a body is again the same features, oval. There is no upper surface. The lower surface has the almost same features: anteroposterior concavity, and the opposite one on the side to side. There is posterior surface, there is opening for basivertebral veins. There is the pedicle is almost hidden, and the transverse process, it is the articular facet. The superior articular facet, it is corresponding to the inferior articular facets of atlas. So it is at the it is on the top of the body, and the transverse process, it's again relatively flat and circular in shape. The transverse process, if we look at it, let's try to look at the transverse process. I'm not able to get a very good look in the superior view. As you can see, this the articular process is overhanging it. It is over it. You can see from here. It is on the top of the articular process, on the top of the foramen transverse area. So when we look at the top, we are not able to see it very clearly. If we look at the side, we are able to look at the foramen transverse area. So this articular process, it overhangs the transverse process, and then we are left with this lamina is again going medial and backwards, and there is spine, and spine is not bifid. Thus there is no spine bifid spine of the cervical spine. So let's see here how we can revise. We look at the dense odontoid process representing embryological centrum of the axis. There is articular facet anterior for the arch of atlas, posteriorly for the transverse ligament of atlas. There is a lateral mass that is having the superior articular facet, and the transverse process, it is hiding, it is having a single tubercle representing posterior, so there will be no intertubercular bar, there will be no costotransverse bar, and foramen transversarium, it is overhung by this inferior articular facet. It is much like that of the typical cervical vertebra, looking downwards and forward, and the lamina is thick and rounded as compared to the typical cervical vertebra, where it had anterior and posterior surfaces and upper and lower borders. And the posterior spinous process, it's massive and may or may not be bifid. In the 3D model, it was from the Elsevier, and they have taken reference from the Grays. They have shown without, and here it is shown as bifid in the netters. So both are correct because it is in. So it is technically in between the two. The superior one having the posterior tubercle, inferior one having the bifid. So it is between the two. So that is for the axis, and then we are left with the last one, that is the vertebra prominens. That is the vertebra prominens. Let's move here. If we look at the cervical vertebra, if we look at the side profile, you can see how much backwards the spine is moving backwards. So that is the way, that is the prominent feature. Its spine is very much longer as compared to the rest of them, and extending back. If you place your fingers on the vertex of your head in the midline, go back a little, you will find external occipital protuberance. Just below the external occipital protuberance, you will have a very deep dip, and after which, in the dip, you won't be able to palpate your spines because they are very far away now. There is anterior curvature of the spines. Go on moving through this skin groove and keep on pressing as you move, go down to roughly the area of your collar here. This point I'm not able to show here in myself. This point you will see a bony prominence. This bony prominence is the posterior spine. This is the namesakes of this cervical vertebra, C7. So this is the vertebra prominens. It has the back, and from here you palpate the C7 vertebra, and this is the first vertebra to be able to be palpated on the back aspect, and you palpate the vertebrae on the surface anatomy all the way down here. And it is not bifid, it is simple. Foramen transversarium is present. It may be more than one as shown in this picture as compared to this one. But a very important question about this is the foramen transversarium from the C1 to C6, it transmits the vertebral artery. The vertebral foramen here in this point, it does not transmit the vertebral artery. That is the very important question that is usually asked in the MCQ. It does not transmit the vertebral artery, but does the rest of the thing that includes the vertebral veins, usually here, and anterior tubercle. if present it is small. That's it about it. And it gives attachments to the suprapleural membrane, the Simpson's fascia you read in the thorax. It originates from the tip of the transverse process of the C7 and moves down to the. So that's it. That's the vertebra. I will not go into the much detail in the for the comparison between the cervical, thoracic, and let me take a break here. I'm leaving it for the food of your thought. With me, it is 12 exact noon. At 12:05, we will continue from here and we will start with the neck. Meanwhile, if you have any question, post in the comments. I will, as soon as you will return, I will answer them inshallah. I have not discussed the joints and ligaments with you. Let's keep it for some other time. Okay then. Uh, let's take a small break. Meanwhile, if any questions, please do comment here. Hello. Okay, let's start here. Welcome back. Let me clear the things. You must know the differences between the vertebra. Just the basic thing is that as you move down, the two things as you move down, the size of the vertebral body increases because the lowest one has to cater for the most weight. So the vertebral body is the smallest, absent in the one, smallest in the C2, and it moves down, it increases. The vertebral canal, it becomes smaller as we move down because the spinal cord is the largest one there, and as we move down, it becomes the shape changes from triangular to circular to again roughly triangular. And then there is transverse processes. These are very telltale for the different vertebra. The cervical vertebra will always have this foramen transverse area. The cervical vertebra usually have, except for the last one, atypical, last two atypical ones, there is this articular facets and the ribs in front of them. All 12 of them have rib in front of them, and the lumbar one have neither. It does not have a foramen transverse area. It does not have an articular process, and that's about it. Let's talk about the neck. So when we are talking about the neck, what exactly region we are defining? So if we talk with the skin, so which parts are there? This, your jawline, the lower margin of the mandible, here the angle of the mandible. From here you will have to make a bony jump from here to the mastoid process, this line, and from the mastoid process go on to the superior knuckle line and external occipital protuberance, and then you will do the same on the opposite side. So anatomically speaking, this is the line that is defining the neck: mandible, angle of mandible, mastoid, superior knuckle line, external occipital protuberance. In the lower aspect, which are the structures that are lining it? Here, the upper margin of the manubrium sterni, that is the jugular notch, because it is present between the two ends of the clavicle. Then there is the upper end of the clavicle palpated here. As you move along the clavicle, you will palpate the acromion process. As you move back, you will find the spinous process, and this whole ring, this area, this is called the neck area. It does not have a lot of surface markings that are important, just a few things. When you extend your neck, you are able to palpate the respiratory tract, the larynx above and trachea below. In males, in genetic males, the larynx is protruded anteriorly to form the Adam apple. This part. Here it is shown here. In the females, um, it is not present. On the lighter note, here is a joke. In the If someone is cross dressed and you are confused about the gender, Adam apple is usually a telltale sign. So there are a lot of jokes in the dramas and the sitcoms that any trap will be having a turtleneck wearing that. Okay, jokes aside, you can palpate you can feel the rings of the trachea. You can feel the cricoid cartilage, thyroid cartilage of the larynx. I will go into the cartilages when we'll take the respiratory system. Just above the Adam's apple, you may be able to palpate the bone here, like this. Palpate your thyroid cartilage, feel the gap, and find the cartilage here. This is your hyoid bone. Just above the Adam's apple, there is a dip and a hard bone here. This is the hyoid bone that is palpated here. And the other prominent feature that is palpated, that is the sternocleidomastoid. When we look at one side, this prominent muscle is sternocleidomastoid. Here it is shown here, and it has two in origin sides from the manubrium and the clavicle, and there is a gap between them. It is palpated here, and in the back there is trapezius. The line here, that is the trapezius. ये वो जगह है जिसको आप कहते हैं ना पट्टे दबा दो, कंधा यहाँ से आप दबाते हैं, you are basically pressing on this free margin of the trapezius. And then this jugular notch and clavicle and acromion and spinous process. So these are the things that you can palpate. In addition to that, you can palpate the carotid pulse. To find the carotid pulse, get to the levels of the Adam's apple, upper margin of the thyroid cartilage, and move laterally here. You can see the pulse right here in front of the sternocleidomastoid, and pulse of the internal carotid artery is a guide to the internal jugular vein that is just lateral to it. And superficially here, the external jugular vein passes. In fair-skinned and thin-skinned and thin people, this vein is prominent, especially when doing some strenuous work and some even at angry someone, the veins gets swollen up, so external jugular vein can be seen crossing the sternocleidomastoid. Okay, let's see the surface. This is the picture from Snell's anatomy. What is the cutaneous supply? Let us divide the back of the neck from front of the neck, and then we will the front anterolateral aspect into this. So I'm marking the line that will be dividing this. It is usually posterolateral aspect of the neck. So let's say behind it is the posterolateral aspect, front of it the lateral aspect, anterolateral aspect. Let's do the posterior aspect first. Behind this red line, the nerves supplying are coming from posterior rami. You remember when in a spinal cord, the nerves exit, there is a posterior root, there is anterior root, they join to form the common spinal nerve, and there is a one posterior ramus and there is an anterior ramus. It supplies the muscles and skin of the back, it supplies the lateral and anterior surface of the body. So this is it we are talking about. Um, okay, this is it what we are talking about. So this is back. Up to the vertex, the highest point. When you stand right and you check your height, the point you touch, this is the vertex. So up to the vertex, the supply is from the anterior aspect. That is from the, I'm not going into the detail of these nerves. These are the from the cranial nerve 5. Behind the vertex, the upper part, all the way the back of the your posterior half of the calvaria and your norma occipitalis, backside and posterior half of the upper aspect. This is supplied by C2. This is supplied by C2 and it is known as crater occipital nerve. There is no C1. There is no C1. होती नहीं है. There is no C1. There is no cutaneous branch. No C1 का मतलब है no cutaneous branch of C1. There is a C1 nerve, but it does not have any cutaneous branch. So we are C1, then the C2 supplying the back, and as you move down, you will have 3, 4, 5 segmentally supplying the posterior ramus of the focus on the posterior ramus. So the back is the back of the back half of the superior surface, and back of the head is supplied by C2, known as greater occipital nerve, and it is the posterior ramus. And as we move down to the back of the neck, there is C3, C4, C5, and after C5 you will jump to you. After C5 you will reach here, the back of your trapezius muscle, roughly at the level of spinous process, and below it the levels will continue C6, C7, and so on. Let's look at the anterior aspect. Let's look at the anterior aspect. Anterior aspect, it is divided like a cross into 4 parts. It is divided like a cross into 4 parts, like this. So I'm removing them. You just remember these lines. So the, let's say it like this: the nerve that is going anterior to the nerve that is going anterior to the ear, the nerve that is going from back of the ear. Here, एक minute, let me tell you one more thing. Just let me draw this. Here along this line, there is a muscle. There is sternocleidomastoid muscle right here. right at this line. See, so all of these nerves, the one, two, three, they are emerging from the posterior margin of the sternocleidomastoid at the same point, and this is also emerging from the posterior margin of the sternocleidomastoid. So all four muscle nerves that I am going to discuss, this one, this one, this one, and this one, these are all branches of cervical plexus. We will discuss this in the last two lectures with the nerves. This is the cervical plexus. So now let's see where all of these four go. So after emerging from the the sternocleidomastoid, the let the two go up and two go down. The two though go up, one goes to the front of the ear, anterior to the ear, and one goes to the back of the ear. The one that goes to the anterior of the ear is called greater auricular nerve, and it supplies the lower aspect of the lower lateral aspect of the ear, part of the external auditory meatus. And keep in mind this part, the angle of the jaw, the angle of the jaw. It becomes important because all of the rest of the face is supplied by the trigeminal nerve, and this is the part that is not. So that is the greater auricular nerve. The smaller nerve that exits the posterior margin of the sternocleidomastoid at the higher level and goes to the back aspect and supplies whole of the medial aspect of the ear, inner aspect of the ear, medial aspect of the pinna, that is the lesser occipital nerve. Now, after emerging from the posterior margin of the sternocleidomastoid, there are some nerves that run anteriorly across the muscle and supply all the skin that is anterior to the sternocleidomastoid from chin to roughly and all the muscle that is anterior to sternocleidomastoid. Follow your sternocleidomastoid, so it will make a triangle like this. You will make a triangle like this. So this whole area from here to here, this triangular area wider above and narrower below, this area is being supplied by the transverse cutaneous nerve of the neck, because it is arising from the posterior margin of the sternocleidomastoid and it is going transversely to the anterior aspect. It is moving, it is supplying this area. So this is the transverse cutaneous nerve of the neck, and we are left with the last nerve that is known as supraclavicular nerve. It arises from here and it moves and expands like this down here. So it expands like this in the midline. It supplies up to the angle of Louis. Otherwise, it supplies by the level of the second rib. So this is the part that is supplied by it. It is further divided into medial, intermediate, and lateral cutaneous branches. Lateral supraclavicular nerves, C3 and C4, it branches this area. This is the topic of the thorax. Beyond that, because after that, the next dermatome is T2. There is C3, C4 with supraclavicular nerves, and just below this, there is T2. Where did all of the rest go? Where did C5, C6, C7, C8, T1 go? So this is the question for you. Answer me in the chat. This is a brain teaser for you. So these are the cutaneous nerves. Very quick revision. Posterior aspect, upper half by the greater occipital, lower part conjunctively by 3, 4, and 5. These are all from the posterior ramus. Anterior part, all of these nerves are rising from the cervical plexus. All of these are coming from the posterior margin of the sternocleidomastoid. The one, two that are going up, the one that is going behind the ear and supplying the medial aspect, that is the lesser occipital nerve. The one that is going in front in the lateral aspect of the pinna and external auditory canal, that is the greater auricular nerve, and it also supplies the margin of the chin. The one that crosses the that transversely crosses the sternocleidomastoid and goes to the anterior aspect of the neck and supplies from chin to the jugular fossa, that is the transverse cutaneous nerve. And the ones that goes and spreads down over the pectoralis muscle medially and over the deltoid muscle laterally and supplies these regions, these are supraclavicular nerves. So moving from the picture of Snell to the picture of Gray's netters, you may be able to see a little these. These are the transverse cervical nerves expanding. This is the sternocleidomastoid. giving, don't be overwhelmed by the rest of it. You may ignore the rest. For now we will do them step by step. And this is the supraclavicular nerves supplying the skin over the clavicle, over the pectoral, over the deltoid, up to the level of angular fluid and second rib. If you look from the side, you will be able to appreciate the rest of the four. So the one that is going, the three exiting here from, if with each other, greater auricular on the surface of the sternocleidomastoid, going to the front of the ear, transverse going to the front of the midline neck, and this is the supraclavicular nerve. It does not come to the lateral aspect of the sternocleidomastoid. You can see lesser occipital. It usually leaves the posterior margin of the sternocleidomastoid just at its point of origin here. And here you can see it is not labeled right now. You can see my pointer. This is the greater occipital nerve that will go up to the level of the vertex. So these are the nerves that are shown here, and all of these are present in the subcutaneous tissue. The subcutaneous tissue, it's the fat like all of the rest of the muscles, all of the rest of the body. It contains a muscle called platysma. I will go into the detail a little while later, especially in the muscles of head and in the muscles of the face. Platysma we will see there. But today we will discuss that today also. And the other thing that is present is the superficial veins, and the vein that is the most prominent vein that is present in the subcutaneous tissue is this one, the external jugular vein. External jugular vein is the one that moves superficial to the sternocleidomastoid. If you have been with me by now, you will have a little idea about now these are all the structures that are on the lateral aspect of the sternocleidomastoid that will help you in the relations, establishing the relations also. There is one more vein in the superficial subcutaneous tissue. It is this. This is anterior jugular vein. It is not so prominent and not so easily identifiable, and it ultimately goes into the internal jugular vein. But there is a paired structure, one on each side, and it moves behind. It goes deeper and moves behind the sternocleidomastoid to go laterally and go into the internal jugular vein, or the junction where it is falling into the subclavian vein. So that's about the skin and subcutaneous tissue. Let's take a 1 minute breather here, and any questions you want to ask you can post in the chat. Then we will move to the last topic for today, that is the muscles of the neck. Ready to move on? Okay, let me. Okay, let's start here. Um, the muscles of the neck. So, which muscles are we going to talk about today? We will talk about the superficial muscles, then we'll talk about the muscles that are above and below the hyoid bone, and then we'll talk about the muscles that are anterior to the vertebral column. The muscles that are posterior to the vertebral column are not the topic of discussion today. Inshallah, we will have some other session for those. So let's dive into it. The pictures are from the netter, the tables are from Snell. Platysma. Platysma is the muscle. It is a very interesting in its origin that it does not have a bony origin. It originates from the deep fascia covering the deltoid. It originates from the deep fascia covering the pectoralis major. So it is originating from the deep fascia from the upper part of the arm and chest. In the lower aspect, it is far away from each other. Their platysma is rising from here, and other one is here, and it will move up and medially through whole of the neck, and it will join here and insert at the angle of the jaw and angle of the mouth. It will have the cutaneous attachment here and the bony attachment here. So what will be the its function? you can see as it will contract. One thing that whenever the muscle contracts, always think about like that, the two ends come together. When this will contract, when it will contract, there is no chance that chest will move up, but mandible will be able to move down and angle of the mouth will move down. So when it contracts, it opens the mouth. And very interesting thing is that it covers the whole of the neck like a sleeve. So it gives an additional layer of protections to the muscles, the structures that are present beneath it. And you may be able to see some of the platysma here if you make face like this. Uh, don't laugh, but still, if you see like this, you see these vertical ridges, these are due to platysma. These are due to platysma. It may not be able to be very visible, but if you make face like this and just place a finger here, you can see a very smooth neck, very soft neck. But if you look at this, you won't be able to press deeper inside because it is covered by taut platysma now. Then there is trapezius muscle. It's a very large muscle. Let's look at its origin only. It starts from here, superior knuckle line, external occipital protuberance, joins the knuckle ligament here, and from T7 onwards, from C7, cervical last vertebra prominens, and spine of all the thoracic vertebra. So it originates from superior knuckle line, external occipital protuberance, knuckle ligament, C7, and all the thoracic spines. So this is its origination, and it's a fan-like muscle, and it's narrow down and it joins here at the back. It joins at the upper margin of spine of scapula. In the lateral end, it is joining the medial margin of the acromion process. If we look at the front, from the front, it is joining the medial margin of the acromion and the posterior margin of the clavicle. So the basically the bony circle that was defining the lower margin of the neck, it is attaching to that. I will repeat, it is attaching to the spine of scapula, it is attaching to the acromion process, and it is attaching to the lateral one-third of the clavicle. So what does it do when it contracts? Sometimes only the upper fibers contract. When the upper fibers contract, it helps in moving the scapula upwards. So this is the shrugging movement. When you don't care about something and when you don't want to answer something. So this moving up of the shoulders, it is due to the trapezius. And this is called the shrugging, that is the elevation of the scapula. And even if you don't elevate, the shoulder is maintaining some of its tonicity and it's maintaining some of its level. And if a person has the trapezius muscle or its nerve, spinous accessory nerve, that is cranial nerve 11, paralyzed, then even when he is or she is at the normal position, the one, if my right side is, it will be dropped down. You won't be able to see the two uh, shoulders at the same levels. The affected one will be dropped down. So this is the one elevation function. Moving on to the next, the rotation function. You can see up the fibers that are placed upwards, that are getting into the clavicle, that are getting to the acromion process, that are moving upwards. The fibers that are using the most medial part of the spinal scapula, that are downwards. So if we look at the perspective of the scapula, its lateral margin is being pulled upward, its medial end is being pulled downwards. So here is the scapula. So roughly here is the scapula like this. Here's the glenoid process will be somewhere here. So when this end goes down and that way goes up, it helps in the rotation of scapula in this direction. So it rotates scapula, upper end goes inside and lower end goes outside. And it is helping you when you're doing overhead abduction. If your scapula does not move, you can only go to maximum the 90 degree, maybe less. About 60 degree you can do that. 90 degree. No, I think I'm making a wrong statement. Let me confirm. It is the range of movement of glenohumeral joint. You can Google it right now. It may give me a break in the monotony. A range of glenohumeral joint. It is 90 degree. Yes, it's fine. 80 to 90 degrees. The rest of the movement, it's due to it is across the movement of scapula. So this movement of scapula, this rotation of scapula, it's brought to you about by the trapezius. So the question comes, there was a surgery in the posterior triangle of the neck and a nerve was damaged. The neck, we will discuss its pathway later on. The neck, the nerve damage is cranial nerve number 11, spinal accessory nerve. And when that is damaged, the person is now unable to comb his hair. They may ask, the person is unable to over abduct the hand overhead और person is unable to comb the hair. It simply means अपना hand वो ऐसे नहीं लेके जा सकता. It is unable to move the hand overhead. And so which nerve is damaged? So this is spinal accessory nerve. Which muscle is damaged? It is trapezius. One confusion arises. The point of confusion is the rotation function this is also done by serratus anterior. I'm not going into the detail the mechanics of it. The serratus anterior do the function and it's like well long thoracic nerve. So if there is an MCQ about unable to do overhead abduction, which nerve is damaged? So you do get confused. I do get confused of which nerve to point. So do I mark the spinal accessory nerve or do I mark the long thoracic nerve? Just remember, long thoracic nerve is passing right here in the medial aspect of axilla. So long thoracic nerve in the medial aspect of axilla, and the spinal accessory nerve, it is moving in the posterior triangle of neck. So if there is no other clue apart from rotation of scapula, overhead abduction, they will give you a clue about where the nerve is damaged. If the nerve is damaged in the posterior triangle of the neck, in the neck, is simply in the neck, it will be trapezius, it will be spinal accessory nerve. And if the muscle is damaged in the axilla, usually axillary clearance is done during mastectomy, then it is due to the damage of serratus anterior. The other thing that will help you and identify the MCQs will be that in the trapezius paralysis, in the spinal accessory nerve paralysis, the person will not be able to shrug. There will be drooping of shoulders. So this is what the trapezius. Let's move on to the sternocleidomastoid. All the originate insertion is written in the name. It is originating from sternocleido and inserting into mastoid. So it has two heads. The rounded medial head is originating from the manubrium sterni. The flat expanded head is originating from the medial aspect of the clavicle, and it moves up and it moves up and it goes and inserts into the mastoid process. The muscle fibers move like a cross. The fibers that were originating medially here will insert laterally there, and vice versa for the other fibers. What function does it perform? So it helps you to look away. It look in the opposite. It rotates head in the opposite direction. So what is the function of the right sternocleidomastoid? It will help turn your head to the left. And when you turn your head to the left, you will feel contracted and prominent sternocleidomastoid running right here. This is one function. The other function is on the joints. Atlanto-occipital joint, it does extension, and this joint and the overall the cervical vertebra, it does flexion. So if I sit like this, um, if you're at looking inside something, when you're looking peeking over something, you do like this. So when you do like this, the part that is here, it is flexing. The part that is here is extending. You may look again. Flexion here, extension here. So that is the function of the sternocleidomastoid. So it flexes the overall neck, but it extends the head. So these are the function, and these are the function of the superficial muscles and the innervation. The platysma we discussed was supplied by the facial nerve. So it is more better studied with the muscles of the facial expression, and the rest of the two muscles, though both have the supply of the spinal root of accessory nerve, and these are the only muscles that are supplied by the spinal root of accessory nerve. In the Snell and in other books, you may find the supply by the transverse cervical nerve. In the last, it is written transverse cervical nerve. In the Snell, it is written C2, C3 spinal nerve. So basically, the other nerves other than the spinal accessory nerve that is going to this muscle is basically sensory in role, is proprioceptive in function. Okay, then moving on to the next component, we see the deep muscles. The deep muscles will be divided into the bases of the hyoid bone. The muscles that are above it, suprahyoid, the muscles that are below it, infrahyoid. You may ignore all the vessels and viscera visible during the process. Just focus on the muscles here. Let's move to the suprahyoid muscles. There is a set of four muscles. Let's start with the muscles that is the mylohyoid. To get a better understanding, um, give me you look at this picture and give me just a minute or two. I will set up the library. Just give me a second. Let me set up a few things. Okay, we are all set. Let's move you all here. Let's look at the suprahyoid muscles. I have removed the skull from the top, and you will be able to see the set of muscles here. The one muscle that is not shown here right now, let's make that muscle available. Let's start with the mylohyoid muscle. Okay, so this is the muscle that is making the floor of the mouth. This is the muscle that is making the floor of the mouth. You see the muscle that is highlighted right here. Where does it originates? It originates from the mylohyoid line that we discussed in the osteology section. Remember, I discussed that mylohyoid line started below the last molar tooth. So this is the mylohyoid muscle, and it attachment moves across all the way mylohyoid lines and meets in the midline. Here, the view is obscured by this pair of muscle right here. This muscle is the geniohyoid muscle. Let's look at this muscle also. Geniohyoid muscle, it is originating from the genital genial tubercles in front and inserting into the hind bones behind. Mylohyoid muscle, it is attaching all the way to the mylohyoid line to the hair genial tubercles. And if you look at from below, where does it attach? They insert into one another. It is like this. They insert into one another, and this white line, the midline, this is called the median raphe, and all the way it gets attached to the hyoid bone right here. You may be able to see hyoid bone. This is the hyoid bone right here, and the mylohyoid muscle, it gets attached to the hyoid bone right here. So, what is the function of the muscle? Anatomically speaking, it makes the floor of the mouth. Above it, there is the oral cavity. Below it, there is a mandibular fossa. What is a submandibular fossa? We will go into the detail later. So, it makes the floor of the mouth. Just think of yourself sipping a Pepsi. When you sip a Pepsi, when you look at someone sipping something through the straw, the floor of the mouth goes up and down, up and down. This part goes up and down. You do this. So this is the mylohyoid muscle. This is the mylohyoid muscle. It contracts and it moves up. Let me see if I can get yes, when it contracts, it reduces the distance between the hyoid bone and the mandible. So either two things can happen. If the mandible is very strongly put in place by masseter muscles, then mylohyoid muscle contracts, it will move the hyoid bone up, and hyoid bone is connected through thyroid ligament to the larynx, and it will be act as the elevator of the larynx. But otherwise, when it contracts, it will act in moving the jaw down. When the hyoid bone is not moving, hyoid bone is fixed, the mylohyoid muscle will contract and it will move the mandible downwards. And this is true for all the muscles that are attached between the mandible and the hyoid bone. So let's look at it. So this is the depression of the mandible. This depression of the mandible is done by mylohyoid muscle. Let me see the mylohyoid muscle if I can get it here. Okay, I'm not very able to do it right here, but you get the idea. Okay, this is about the mylohyoid muscle. I will go to the innervations in the end. Then there is geniohyoid. This is the geniohyoid. It is anteriorly attached to the genial tubercles, posteriorly attached to the hyoid bone, so its function will be exactly the same. When it contracts, it will reduce the distance between the two. So it will either raise the hyoid bone with the larynx, or it will depress the mandible, otherwise opening the mouth. You don't need any muscle to open the mouth. कभी आपको कभी कोई चीज सरप्राइज करती है, मुंह खुलेगा खुला रह जाता है. But if you put a pressure here and then these muscle come into it. Then you will feel these muscle. You can place a finger here, and then you can feel the muscles contracting. So there are two muscles, mylohyoid, and we discussed mylohyoid and geniohyoid. For the next two muscles, we will have to get skull in place. So let's get skull in place. Calvaria scan. Let's get it here. Okay. So these are the muscles. First, let's talk about this muscle, small one. This is called stylohyoid. For the head and neck, the very interesting thing is that the name of the muscles give away their origin and insertion. So this muscle is originating from here, the styloid ligament. And if you follow, it moves all the way there and it inserts at the junction between the body and the greater horn of the greater corner of the hyoid bone. So this is stylohyoid ligament muscle. And the other muscle that we will see, it's this digastric. It has two bellies. Digastric, two belly muscle. So what are the two bellies? So this is the posterior belly. In the osteology portion, we discussed the digastric fossa in the inferior margin of the mandible. So there is this anterior belly that originates from the digastric fossa, the anterior margin of the inferior margin of the mandible. It moves to the hyoid bone. Interestingly, it does not attach to the hyoid bone. There is this sling, there is loop, fibroelastic loop that is attached to the hyoid bone. It is like a pulley and it changes the direction of the fibers. The tendinous part becomes fleshy again, and this is the posterior belly of the digastric, and that attaches to the mastoid process, and it attaches to the medial aspect of the mastoid process. That was the digastric groove that what I was getting confused in the last slide little. So this is the digastric muscle. Anterior belly attached to the digastric fossa in the inferior margin of the mandible. Tendinous part that is changing its direction from the fibrous sling attached to the hyoid bone and that posterior belly of the digastric. So these are all the muscles as we see them. Mylohyoid, the flat muscle forming the floor of the mouth. It was helping in elevating the floor of the mouth. It was helping in depressing the mandible or elevating the height if the mandible is fixed. The geniohyoid, it is from the genial tubercles to hyoid bone, and it was helping in the same as mylohyoid but not excluding the function of wo. Then there is stylohyoid. It is from the styloid process of the skull. It cannot be moved. So we are only left with elevation of the hyoid bone and respect, and then from it the elevation of the larynx. And then there is posterior belly of digastric. So it is like this link. When it contracts, it moves the hyoid bone upwards. So these are the muscles. So let's move to the presentation. You can see the summary of all those things here. You can pause the slide, take screenshots, and look at the muscles. And the thing that I would encourage is open the netter for yourself. The thing that we are left with it's nerve supply. It's a little tricky, but do spend some time in memorizing that. The muscles that were coming from the base of the skull, which of the two muscles were coming? It was the styloid muscle and the posterior belly of digastric. So these two muscles, these are being supplied by the facial nerve, the muscles supplying the face, the nerve supplying the facial muscles. The same nerve supplies these two muscles that are attached to the base, styloid and posterior belly of digastric. देखिए ये एक ही मसल है जो कि आ रहा है स्लिंग कर रहा है, बट इट एक्ट्स लाइक two separate muscles. So posterior belly of digastric, there are two muscles. So we are left with anterior belly and my anterior belly and mylohyoid, and then there is geniohyoid. The anterior belly of the digastric and mylohyoid will have the same nerve supply. The trigeminal nerve has three divisions: maxillary, ophthalmic, maxillary, mandibular. The mandibular division is further divided into anterior and posterior parts. The posterior part has an inferior alveolar nerve that is coming to supply the lower teeth. And there is a branch of the inferior alveolar nerve that is the mylohyoid nerve. It is named against the muscle it is supplying. The nerve to mylohyoid supplies the mylohyoid muscle and the anterior belly of digastric. By the time you have studied the cranial nerves, inshallah you will be able to remember the whole chain. But for now you must remember that mylohyoid nerve is ultimately a branch of mandibular division of trigeminal nerve. So this is it. Then we are left with genioglossus. This in this view we are looking from the inside. So this is genioglossus. It is supplied by the cervical plexus, C1 fibers supplying the from the hypoglossal nerve. Hypoglossal nerve supplies all of the muscles of the tongue, and C1 fibers, they get a piggyback ride on the hypoglossal nerve to supply this mm, genioglossus muscle. So that's it. That's the suprahyoid muscle. We are left with then infrahyoid muscles. Let's get back to our presentation. Let's get back to our model. Let's add a few things here. Let's add the larynx here. Then we will add the trachea here. Then we will add the thyroid membrane. And in the end, let's add the infrahyoid muscles. So these are the infrahyoid muscles. Let's look at them. Okay, they are in two layers. There are two muscles in front and one on the back. And very good news for you is their names are based on their attachments. So the first muscle, it runs from the hyoid bone here to the sternum there. See, it is attaching to the posterior aspect of the manubrium sterni, and it is attached to the inferior margin of the hyoid bone. So what will be its name? Sternohyoid. It is going from sternum to hyoid bone. It is sternohyoid. It is unable to move. It will be unable to move the sternum up, but it will definitely be able to move hyoid bone down. So it will be able to to pull hyoid bone down to depress the larynx. So it will be a depressor of larynx. All of these muscles are depressor of larynx. Not all of these. We'll go through them one by one. Then the second muscle is on its side. This this is called omohyoid. Omohyoid. Omohyoid muscle. Uh, Omohyoid muscle has two bellies. It has superior belly and inferior belly. Um, Let me show this, and let me arrange. Okay, so we were talking about omohyoid. So what are the insertions and origins of omohyoid? Omohyoid, it superior belly, it arises from the hyoid bone. It arises from the hyoid bone like this, and it has again the two belly, and in between the two bellies there is again the sling, just like there was of the digastric. This sling is attached to the clavicle and the first rib, and then there is the inferior belly. This inferior belly, it goes and it inserts into the upper margin of the scapula. So this is the omohyoid. So when it contracts, it will again pull the hyoid bone down and depress the larynx. So these are the two muscles. Let's remove these muscles and see what is beneath them. I'm keeping the muscles on the side on its place, but on the right side I have removed these muscles. So when you remove these muscles, when you dissect these muscles, you will see two more muscles just behind it. These are called, one is between this cartilage of the larynx, it's called the thyroid cartilage. The one that runs between the hyoid bone and the thyroid cartilage, it's called thyroid. So it is then always an elevator of larynx because it raises the larynx, raises the thyroid cartilage up towards the hyoid bone. And then there is sternothyroid. It is always the depressor of larynx. It pulls the downwards. So these are the four infrahyoid muscles. These are the four infrahyoid muscles, and I will just quickly remind the names. And the anteriorly there is sternohyoid, then there is laterally anteriorly there is omohyoid with two bellies. If we remove them, behind them there is sternothyroid, and then there is sternothyroid and thyroid. Apart from thyroid, all of the others are depressor of larynx. This particular thyroid is the elevator of larynx, and all of these are supplied by various branches of ansa cervicalis. Okay, so we are done with these muscles. Then there is Scalenes muscles. Scalenes muscle is the one that arises. All of the three Scalenes muscles, they arise from the transverse process of the cervical vertebra, and they insert into the first and second rib. So the Scalenes anterior muscle, it arises from the transverse processes of typical cervical vertebra C3, C4. You can see C3, C4, C5, C6, and it can inserts into the raised portion on the medial aspect of the first rib, that is the Scalenes tubercle, first rib on the medial aspect. What does it do? It may either raise the first rib or it may pull the vertebral column towards itself, that is lateral flexion. Then there is Scalenes medius that is present just behind it. It usually arises from all of the cervical vertebra transverse processes or upper six, um, and then it gets inserted into the posterior aspect of the upper surface of the first rib. On the behind all of the back, it is not very visible right here. That is, it is a little ill-defined muscle that is Scalenes posterior. It arises from the lower transverse processes of lower cervical vertebra and it inserts into second rib. All of three have similar function in aspect of elevating the ribs. Either it is first or second, and pulling the cervical vertebra towards themselves, that is lateral flexion. All of these are supplied by the anterior rami of cervical nerves as they are exiting the intervertebral foramina. The Scalenes anterior, it is very important as an anatomical landmark. Let me remove myself here. I am blocking a few text. The Scalenes anterior, you may take a snapshot of this slide. Scalenes anterior relations are very commonly asked in an exam questions. Anteriorly, if we look at here, Scalenes anterior, anteriorly, one of the which questions are most commonly asked, the two things that you have to memorize. This is the anterior relation, the phrenic nerve, don't forget that, and the subclavian vein. These are the must remember. Scalenes anterior, anteriorly Scalenes anterior, there is passing of subclavian vein and there is phrenic nerve that is passing ahead of it. These are the most important one, but there are many and most of them are important. The fascia that is covering it, that is prevertebral fascia. This is the subclavian artery going through. The subclavian artery has three parts. The part that is medial to the Scalenes anterior is first, behind is second, lateral is third. So the it is in on the we will see in the posterior relation the second part is behind it. We will discuss tomorrow inshallah the arteries. This branch costos cervical trunk, this arises and this becomes in the anterior relation of the Scalenes anterior and all of its branches: inferior thoraid, ascending cervical, inferior thoraid, transverse cervical, suprascapular, all of these. And they have again these things. And then there is sympathetic ganglion, sympathetic chain in the upper part, it moves ahead of it, and prevertebral fascia. And then there is carotid in the upper part, there is carotid sheath and its contents. It is cut right here, but if you follow up, but there is carotid sheath and its contents that includes the common carotid, internal jugular, vagus, and all these lymphatics. So these are the anterior relation. The structures that is passed behind posteriorly, of course, there is Scalenes medius behind it. Remember, there is subclavian artery. This is the most important one to remember for the exam point of view. Subclavian artery. So this point of information is asked very commonly. Which is the muscle, which structure is present anterior to the Scalenes anterior subclavian vein, posteriorly subclavian artery, which muscle is present between the two Scalenes anterior. So आपसे ये किसी तरह भी पूछा जा सकता है. और Scalenes anterior and Scalenes medius के दरमियान से सारे plexi निकलते हैं. दो plexi, that is brachial plexus and cervical plexus, that are present between the two Scalenes muscle. We are left with medial and lateral relation. Let's do the lateral relation first. The third part of the subclavian trunk, and there is a dorsoscapular artery. We will go into the detail inshallah in the next lecture. And the branches, the trunks of the brachial plexus, they exit and go. And you had seen in the cutaneous supply the greater auricular and oh, just leave them there. So the trunks of the brachial plexus, they exit here. We are left with the medial aspect. Medial aspect has this space. This is called pyramidal space. The pyramidal space is this triangular space right here, base right here. This triangle space is made up of Scalenes anterior medially, longus colli medially, and subclavian artery on the base. And on the top in the apex there is carotid tubercle of chestic neck that we discussed earlier. So this is about the parotid. So pyramidal space is present here, and then there is first part of the subclavian artery. All of the branches of the first part we will discuss later. Inferior sympathetic ganglion and ulcer cervicalis. What is that? We will see that in the hand, and the thoracic duct as it arches over the subclavian artery to go into the subclavian vein. So these are the relations of the Scalenes anterior, and due to these relations, it is very important for the anatomists and the surgeons to as a landmark. And due to all these things, it is known as key muscle, and it is due to the relations. And we don't remember Scalenes due to its function; we remember it for its relations. So this is from the Snell, and this is the picture from Moore's clinical anatomy. You can take a screenshot and um, go through them also. We are left with the sternocleidomastoid relations. Sternocleidomastoid laterally is anterolaterally it is related. Superficially it is written here, and the other one is will be laterally. So laterally it is related to the skin, superficial fascia, the vein we discussed, external jugular vein, and the nerves we already discussed, that is greater auricular and transverse cervical nerves. On the medial aspect, in the deep aspect, there is cervical plexus, there is bulky posterior aspect, there is cervical plexus, phrenic nerve exiting, and brachial plexus in the upper part. And anteriorly, there is majorly the thing that you have to remember is carotid sheath and its contents. You will list all of these contents as carotid artery, internal jugular vein, deep cervical nodes, and then there is thyroid gland present here also. And under the surface, you will see Scalenes anterior, medius, and all the things that we just discussed here. So these are about the Scalenes muscle, sternocleidomastoid muscle, their relation, and just the last part of the lecture today. Um, this is prevertebral muscles. This is a very interesting picture that I found. I think it was in Indraveer Singh. So it has divided the group of muscles in different parts. We discuss the subcutaneous muscle. We discuss the muscles in the outer ring. Oh, I just found out that you cannot see me. The fasciomuscular column, the one that is embedded in the investing layer of deep cervical fascia. What is investing layer of deep cervical fascia? We will discuss it tomorrow, inshallah. It had anteriorly sternocleidomastoid, posteriorly trapezius. I skipped levator scapulae. Then there was anterior muscular column, suprahyoid four muscles, infrahyoid four muscles. Then prevertebral muscles. This is the part that we are going to discuss. That is anterior to the vertebral column. We have discussed this prevertebral muscles. In the prevertebral muscle, we have discussed the one that are lateral to it. Scalenes anterior, medial, and posterior. We have not discussed the scalenes medius. The extrinsic muscle of the back, intrinsic muscle of the back. I'm leaving it from this course. I'm going to now discuss these four muscles, the two rectus capitis and longus muscles. So these are in front of the vertebral column, superior to the mediastinum, and they are covered by prevertebral fascia. These are the two muscles that are originating from the first cervical vertebra and going to the base of the occiput. These are rectus capitis. The one that is medially, it's called anterior, that arises from the lateral mass and root of the transverse, and it inserts into the base of the occiput. And it helps a very weak flexors of the atlanto-occipital joint. Rectus capitis lateral, as you can see, it is arising from the late transverse process, and it is inserting into the just near the jugular opening, jugular process. It is supplied by the C1, C2, and it helps in the lateral flexion. Of course, it is a very weak muscle. Then there comes the longus capitis. Longus capitis is the one that is attached to the base of the skull superiorly and to the and it is attaching, well, it is attached to above, it is attached to the base of the skull, base occiput, and below it has the same attachment as the scalenes anterior, that is the typical cervical vertebra, C3, C4, C5, C6, transverse process, same as scalenes anterior. So this is longus capitis. It helps in the lateral flexion and anterior flexion of the neck when two of them are working together. This whole muscle, this is longus colli. Medially, it is attached to the anterior tubercles of the atlas bodies of the C1 to T4 all the way. It is attached to the bodies, and laterally these are attached to the, again, C transverse process of, again, that typical cervical C3, 4, 5, 6. So it acts as the flexor of the vertebral column. It has three parts: the superior part that is attached to the midline here and attached to the um, transverse processes. The inferior part is attached to the midline here in the thoracic part and attached to the lower transverse processes. And the middle part that is attached, vertical and intermediate part that is attached to the upper vertebral bodies and attached to the lower vertebral bodies. It is arising from vertical bodies anteriorly to vertebral bodies inferiorly. It using the flexes anteriorly, and the oblique part helps lateral flexion, and inferior oblique part rotates the head to the opposite side. Longus colli we have discussed. There is longus colli, superior oblique. I'm leaving these for you. You may take screenshots and read about them, but these are the ones we have discussed. Okay. Just, I think it's a good place to end the lecture here. I have been uh, eating your minds for the 2 hours now. So thank you so much for being here and being live with me. Uh, Please let me know if you have any questions, suggestions, or feedback for the lecture. If you have any, I may address it right now. Then I will close the lecture, and otherwise, you may mention them in the comments later. So I will stay live for a few minutes. So if you have anything to say or ask. Thank you so much. So nice of you. Inshallah, see you in the next lecture. Till then, good luck and Allah Hafiz.